Hello, everyone, and welcome back here in the heart of Paris, where ESC conference is taking place. I'm Inga, and today together we will dive into one of the hottest topics, viral pulp treatment. It's a huge privilege for me to introduce our outstanding guests, Professor Chilalo Boukpessi from the University of Leuven, Belgium, and Professor Georgos Tzanetakis from the University of Athens, Greece. Thank you guys for joining us. And today we are asking, is saving pulp is a clinical breakthrough or is it still out of reach? Let's find out. So, Professor Chilalo, when we talk about viral pulp treatment, what does that encompass in our clinical terms?
Thank you very much for the invitation. I'm very happy to be here. And let me say that vital pulp treatment is not a novel technique modality, right? It is rather old. And I can say that the better and better we learn about the pulp biology, as well as the development of a new family of cement as hydraulic calcium silicate-based cement, together they have increased the success rate as well as the reliability of this treatment. So today, a lot have been done, and now we can do the vital pulp treatment. And this means that we have new silicate cement that help a lot for having this reliability, this success rate. We learn about the diagnosis. Even this is the mainly challenge part of the story. And yes, I think today we can talk about reliability of phytopulp treatment.
Professor Georgos, um, a growing interest in viral pulp treatment is undeniable. Yes, we all agree with that. So, what developments have led us to adopt that viral pulp treatment is become a standard approach in our clinical practice?
Um, Thank you for the invitation. It's a great honor for me to be here to talk about vital pulp treatment. Certainly, the first comes from knowledge. Now we have certain information from clinical trials and histological studies that a great amount of pulp tissue is free of inflammation, even in cases of irreversible arthritis, so we can preserve this tissue. So knowledge is the first advancement we have for vital pulp treatment. After that, we have some technological advancements. We have the magnification in order to visualize appropriately the pulp tissue, in order to see if this pulp tissue is capable of if it is capable of healing. And last, we have improved our materials. Our materials now create a safe and stable environment for the remaining pulp tissue.
I would appreciate your insights. And does the success of viral pulp treatment only depends on materials, on the new technologies, or this is a paradigm shift in our clinical thinking more important?
Yes, I agree with that. Preoperative diagnosis is essential in order to manage appropriately the pulp tissue if we have following a carious pulp exposure. But also it's very important the intraoperative evaluation of the tissue after each exposure.
Comparing conventional root canal treatment and viral pulp treatment, what are the main benefits and limitations from the both perspectives, from the dentist and from the patient? You can.
Yes, let's say that what the preservation of pulp vitality offers is the vitality. So this is really important because the pulp is the only tissue that offers the self-protection of the tooth, right? So as soon as there is no more pulp, there is no more now self-protection of the tooth. So as long as we can preserve it. So let's go and do it because for the patient, this is the best we can do for him, right? So the patient let's say, benefit, I think this is the most important. You know that if you would look at the therapeutic gradient of the treatment that we can do for the patient, as lower is the way we touch the tooth, as better is the tooth, right? And we all know that cross-sectional studies have demonstrated that in the overall population, the reality of success rate of endodontic treatment is not the same that in the studies, right? If you look at the cross-sectional studies, only between 33 and 65% of endodontic treated teeth exhibited no disease. So this is the point, right? And on the clinician perspective, we also want to treat the tooth as well as possible. And who treat endodontically a tooth know how it's difficult also to treat the tooth, right? Because of an anatomy challenge and so on. So yes, both parts, this is beneficial for me, okay, to preserve the pulp vitality. Even we have today many questions still, but research is doing, and maybe we'll have better and better response in the future.
So the rule less is more here fits perfectly, yeah? Would you like to add something on this question?
No, I agree with that all said by Chilalo. I think that nobody wants to have a root canal treated tooth in their mouth. So, for my experience, I can say that most patients can accept with pleasure the vital pulp treatment because we explain them that we have a vitality inside their tooth, so this is something significant for them. This is from the patient benefit perspective.
You've mentioned materials.
Yes.
Hydraulic calcium silicate cements, we know as bioceramic materials here is game changers, yeah? Why and how these materials enhance our clinical success in mature permanent teeth?
Yes, we know from several studies that calcium silicated materials nowadays are very improved because of their high biocompatibility against pulp tissue, their bioactivity potential, the inducing odontoblastic differentiation within the first 1, 2, or 3 days. Subsequently, you have mineralization and dentinal bridge formation. So all these properties do these materials appropriate for pulp capping. In addition, we have an improved sealing ability of the material compared to calcium hydroxide in the past. We know now from histological studies that we do not have the development of a zone necrosis between the material and the pulp tissue as occurred previously with calcium hydroxide. So this interface area, remain free from inflammation. It is very important for the preservation of the remaining pulp tissue.
And Dr. Domenico Ricucci, he published his research
Yes.
a few years ago by using calcium hydroxide cements and with over than 30 years of follow-ups. But the question will be, which materials should we use today in our modern dentistry? So, as we are talking about viral pulp treatment, I think that we are talking now about new materials, about bioceramic materials.
Yes.
Yeah? Do you agree with that?
Yeah, I totally agree with your comments because we know that I remember my PhD work, okay, on hydraulic silicate cement. At that time, it was biodontin before it becomes biodontin, and we work on rats. And at that time, we demonstrated and we published many years ago that the quality of the mineralized barrier is different depending on the material we use. And even calcium hydroxide was the treatment, but the gold standard material in the past, today is not the matter we have to talk about, even it could help in maybe few cases, but yes, hydraulic silicate-based cement are the best we have to do to use today because of many purposes that you just mentioned, and also we can add that they will also promote the angiogenesis, and by increasing the level of growth factor that promotes angiogenesis. So this is a point that we can, yes, highlight in the discussion also. Okay.
Thank you for your insights. And let's imagine two scenarios. One day you perform vital pulp treatment and the patient come back with the pain. And the second scenario, you perform a root canal treatment and the patient come back with a swelling, with a huge pain after a few years. So in the first scenario, the patient for sure will remember you, yeah? But while in the root canal treatment case, maybe you even forgot who performed root canal treatment. My question is about fair. Is it fair choosing root canal, vital pulp treatment are mostly driven by psychological factors?
This is a very interesting point because currently we are doing a questionnaire for practitioner dentists, general dentists, and this is a point that we highlighted. Even we didn't publish yet the study. This is the fear that the practitioner can feel regarding the pain that the patient could experience. But I think better and better, we have studies that will help to answer that, because one of the studies I have in mind is one of a Belgium team. They have investigated the short-term evolution of pain in two different treatments of irreversible pulpitis, meaning they compare conventional root canal treatment with pulpotomy. And what they found out is that there is a significant decrease in the pain post-operatively, but also there's no difference between both groups. Okay, so this is kind of answer.
Thank you for your answer. And yesterday there was an EAE and ESC meeting regarding pulp diagnosis. Could you share any gossip? What kind of changes are waiting for us?
Yes, a very interesting question. Um, Personally, I have some doubts about the new classification. I'm not sure if this classification fully adopts all the clinical situations. There are some clinical situations that I believe are not fully described in their classification. So we should make some suggestions about the classification. For example, we have a clinical situation which the patient has referred pain. The patient is not be able to locate the responsible tooth. The tooth is not sensitive to percussion. Such conditions should be described inside the new classification, so to provide with some useful information and some guidance to dentists in order to fully diagnose every case appropriately.
Can I add something? Because even it's challenging, I think it's, let's say, for me, on my opinion, it is important. Why? Because during many years, we, we were thinking reversible, irreversible, and the diagnosis of irreversible pulpitis is the goal for the need of root canal treatment. This is what we have in the mind, but this is not reflected by the recent publications that use partial or full pulpotomy to treat irreversible pulpitis. The success rate is really high. So, as irreversible pulpitis was meaning root canal treatment, I think we have to avoid this fatalistic term. Even I don't know if severe is better, but I think the the way that we are thinking now has to be changed, and it's for people, on my opinion, needs to another world. But the thing to the point I can say is we have to congratulate these two societies to for trying to have the same message. And this is a point that we have to be proud of. So for me, it's a good point.
Thank you. And as a clinician, how do you decide to go for root canal treatment or to go for vital pulp treatment?
Oh, sorry.
At first, we should have a vital case. If we have a vital case, then we will consider a vital pulp treatment procedure. After that, we should diagnose properly every case. If a vital case, when we have appropriate positive sensibility test, when the radiograph gives us some information about the condition of the periapical tissues, then we have to consider a vital pulp treatment procedure. In cases we have a necrotic pulp with or without apical perioditis, some vital pulp treatment failed cases, then we go for root canal treatment.
Now it will be a very practical question. Is it easy technically to perform vital pulp treatment? And what are the main challenges dentists face when performing this procedure?
Let's say that it's easier than root canal treatment, right? If we think about full pulpotomy, this is something we use to do when we perform root canal treatment. So this is technically something we already know how that functions. But if we want to have the best success rate, we have to follow the guidelines of EAC with the S3 level recommendation. And this is really clear. Okay, so different steps have to be followed, starting from the rubber dam, magnification, and many, it's not like many devices, but just, okay, I have to see if my pulp is red, there is no necrotic pulp there, if I have the biomaterial that is necessary for the pulp capping. So in theory, it's easy, but we have to follow steps. And if you want to have the good success rates, okay, so just follow the steps. And yes, it will be easy.
How do we define success of vital pulp treatment? Which signs or tests indicates that that pulp inside is still vital? How can we check it?
Yes. First of all is the absence of symptoms, the absence of radiographic signs of pulp necrosis or apical perioditis, and for sure we should have positive sensibility test. We have some other indirect signs, such as tooth functionality. The tooth should be comfortable and functional. The dental and bridge formation is an indirect sign that we are on the right way. And don't forget the immature teeth. We have continuation of root development in immature teeth and complete apical growth. It's a perfect sign. It's my favorite sign of that the tissue remains vital and do the work we want.
And now let's talk about failures. We love failures, especially when it happens to our colleagues, yes?
Yes.
So what challenges or complications have you experienced in your clinical practice? Professor?
There are two types of failure, right? Early failure and later failures. And we just finished a study in our clinic that we are going to publish on this 10-year, up to 10 years follow-up after our treatment. And the short-term, let's say, failures could be treated with root canal treatment. This is almost the case when the diagnosis was not the good one, okay? Because this is the challenge for this vital pulp treatment. The main challenge is accurately assessing the pulp inflammation. And today we don't have the best device to perform this diagnosis. We all know that the record of the pain story is really subjective. You also know that irreversible pulpitis could be asymptomatic in many cases. So, okay, this is a point, and we should, yes, uh, um, use root canal treatment to treat this failure, this early failure. But what we found out also in this study is the late failures. These are more due to the, let's say, the coronal part of the tooth. Sometimes it's caused by the new caries, and the endodontic part of the tooth is perfect. There is no lesion, there is no apical lesion, only uh, uh, a secondary caries comes. So I think we can manage this with our, treat secondary caries is not a problem, right? So
And how about calcifications?
yeah. So classification is a fear also for dentists, right? Because if you have to uh, to um, to treat a tooth with apical periodontitis with calcification inside the root canal, this could be difficult as well. And for endodontists, could be easy, right? So because we used to do that in everyday practice, but for general dentists, this is a point. So yes, for that we agree for this difficulty.
Agree, totally.
Totally agree.
Totally agree.
And how about internal resorptions?
Uh, yes, internal absorption may be a complication following a constant pulp inflammation and irritation. But in my humble opinion, based on my own study and my observation, my empirical observation, I haven't seen any case of internal absorption. The main failure is pulp necrosis. We can see calcification and root canal calcification, especially in cases of full pulpotomy. But I haven't seen so far an internal absorption case.
Let's imagine if viral pulp treatment becomes the gold standard. How dental education will adapt and how all our endodontic books will adapt to that.
Yeah.
And what would be the best way to teach students or to teach the dentist how to perform vital pulp treatment, and not in the clinical cases, but on the tooth models?
Yes.
I totally agree. The dental education has to adapt with this new way to treat the patient, right? And I think it depends on the university, it depends on many things, but a lot is doing more and more. And for instance, in our university, there is a workshop on vital pulp treatment, how to deal with the pulp exposure, how to deal with avoiding the pulp exposure, how to deal with the direct pulp capping, the partial pulpotomy, and so on. And this is possible because of the development of 3D models. So we have to work with the developers of these dental education models, and this is also something is going on. So I think everything is in progress. I think everything is changing with artificial intelligence, with everything. All professions are going to change in the future, right? And dentists also. So we have to adapt. And this is my, optimistic way to see this.
Totally agree. Yeah. Would you like to add something?
Yes, I totally agree with the answer of Chilalo. It's very important to me for the students to be taught about the vital pulse treatment procedures, every vital pulse treatment procedure. We have already incorporated the teaching of vital pulse treatment procedures in our postgraduate and undergraduate education. Our postgraduate student should perform at least 20 vital pulse treatment procedures before they graduated. So, especially in the undergraduate education, when we have the opportunity, we perform vital pulse treatment. So, yes, it's very important, as well as the dentist, as Chilalo said, it's very important to adapt the vital pathogen procedures in their clinical practice.
Yeah. Totally agree with you. Yeah. Promise, the last question. um, put yourself into the patient's shoes. Which treatment, vital pulp treatment or root canal treatment, would you pick for yourself?
Vital blood
Vital,
treatment.
of course, vital pathogen, of course.
So this is the key answer, and this is the answer how we should treat patient nowadays. And tomorrow at 9 in the morning, in Hall 3,
Yes.
it will be Vital Pulp Symposium. So we sincerely hope that your morning after tonight's party will be kind enough you to let us join us. Thank you for being with us. Don't forget to share all memories on social media and stay tuned.
Thank you.
Thank you for the invitation. Thank you very much.